I would like to introduce Dr. Julian Baudinet, who is a consultant clinical psychologist at South London and Maudsley Hospital, mainly working with children and adolescents with eating disorders. Over to you.
Thank you. It's good to be here. Yes, so I'm really here from the Child and Adolescent Clinical Service. I also dabble in research. But what I'm hoping to talk to today is make it much more local and think much more about the treatment that we're offering clinically in our services. And what are we going to do next? Because as many of you know, the child and adolescent field of eating disorders has been very dominated by family therapy, hasn't it? So really from the 80s, many of the trials done here. We know that it's now reached the guidelines. It's really the first line evidence-based treatment here and internationally. It's been manualized in America. We've got manuals here. But it's also fair to say that not everyone gets better through family therapy, right? We have a significant minority of people that come in with anorexia nervosa that receive family therapy, and it's clearly not enough. And if you look at the data that we have, or the best available data for bulimia nervosa, it's certainly, it's wanting, isn't it? So we have a really high proportion, if not the majority, who will not be abstinent from bulimic symptoms by the end of our family therapy models. Now, as the first line treatments, I'm glad we have them, but it sort of suggests there's plenty more to do, right? And I think in some ways we've been doing the same thing for a little while, and we've been thinking a lot in the last sort of 5-ish years, at least since I've come in 2017, about, well, what do we do with that? So I'm going to present a little bit of data, but maybe more some ideas about where we're hoping to head. Yes, like I said, lots changed since the 80s, since this sort of first came into play, right? So when we think about, well, okay, well, fine. So what do we do with these outcome data? If we look at the quantitative data, like that's available, so think predictors or moderators or mediators of outcome, we can kind of see that there's a bit of data. Probably the best data that we have is early change is really important. There's something about the first few weeks or months of treatment. So that's both weight gain, but also actually psychological change. I put that up there too, okay? It's almost at a point where if we don't see early change, we probably need to think pretty quickly about what else we're gonna do. It's not just that though, there's something key about engagement and alliance. There's something about caregiver and family factors. So there's something about families that come into treatment that have really high expressed emotion or criticism, whichever direction, wherever it is, wherever there's low support, they tend to respond more poorly to the treatments that we have. So we need to think a bit more differently about that. But there's also sort of team stuff. There's also reflective functioning capacity. Okay, so there's a bunch of domains that we know from the data that we can look at to think, well, what do we do with that? We've also gone back and done a long, well, do you call 7 years long? I don't know. We've done on average a 7-year follow-up study, right? So we did an audit of our caseload from quite a while ago, and then this study was published, I think it was 2021, might be early 22. The QR code is there if anyone wants to check it out. But so we thought, well, let's go see actually how are people responding in the years after the treatment that we offer in our clinical practice. And what was really interesting is actually not that many people had a current diagnosis of an eating disorder. And most said that they were not significantly impacted by eating related difficulties, although some were obviously. But around a third had sought help during the follow-up period for an eating disorder, and of those 20% had received more intensive type support. So whether that's prolonged treatment, in day program treatment, inpatient treatment. So again, it's not everyone, but actually that's a relatively large group of people, isn't it? And perhaps more striking to us was that there was a very large group of people that required support or had sought support for other mental health difficulties, mostly anxiety and depression. And while most were saying this didn't interfere too much in their sort of daily life, they were seeking help, so it was significant enough to warrant looking for extra support. And while two-thirds said that didn't impact too much with their social well-being, I'm more struck by the 1/3 that are saying it did, right? So again, giving us some clues about where we want to head with all of this. So then the other place we've been looking at to think, okay, well, what do we do to refine our treatments or to improve that gap in outcome is go back to some of the genetic temperament, biotemperamental profile data that we know is being generated, right? So think about all the studies from this morning, and elsewhere. And I guess what has begun to emerge over the last 10, 20 more years is there's a relatively distinct biotemperamental profile. Now, of course, these are generalizations. Not everyone that comes in with anorexia or bulimia nervosa is going to present with all of these factors, but there are trends, aren't there, right? So things like threat sensitivity, anxious temperament, flexibility, harm avoidance, intolerance of uncertainty, all of those types of things tend to be associated with a diagnosis of anorexia, but not all, and it's constantly evolving. And then when you map that onto bulimia nervosa, it's a little bit different, isn't it, right? So we want to be making sure that what we're offering is not the same. And is there a way that we can think, well, what are we doing for different traits, profiles, individual people, right? Again, tapping into this idea, it's not one size fits all. I think we definitely need to move away from that idea. So we did do a bit of work within our own clinic, just thinking, okay, so who's coming into our clinic, right? Does this bigger data that we're reading about fit with who's coming in? So with about 130 of our young people who are underweight, so about 82%, what we did find is actually eating disorder symptom severity, so on the EDEQ, was significantly correlated or associated with increased risk aversion, social withdrawal, reduced social connectedness. So again, not the number of people that people have in their network, but how close, that the quality of that connection, which I think is a really important factor to consider. Inflexibility, reduced quality of attachment relationships or relationships within families or with caregivers. I thought this was also an important one, which is the increased suppression of emotional expression, right? So it's not the experience of emotions, obviously, it's how much we're bottling them up or not expressing them to other people when they're occurring for us. And lastly, there's something to do with the severity of symptoms and then reward sensitivity. So this is looking at how much we look forward to things. And then when we're in an enjoyable experience, can we sit in it and enjoy it for what it is, right? So it does kind of match on relatively well to the data that we found. What do we do with it, though, is the question. But we were also beginning to think, okay, well, what about beyond the eating disorder symptom severity? And we started looking at comorbid depression symptom severity. So this is just a cross-sectional mediation analysis, mostly correlational, it's not temporal. So caveats, right? But what we looked at is what we found is this idea about how much do we suppress our emotional expression, how much we're showing it on the outside, certainly is predictive of depressive symptoms as well as eating disorder symptoms. And if we control for weight, it's also mediated significantly by how connected we feel to others, right? So it seems to protect us against this trait or emotion regulation coping strategy if we have higher quality connection with others. So it's sort of a little marker there. And the other thing that social connectedness seemed to mediate against was inflexibility, right? So the more inflexible someone was, generally it tended to predict depressive symptoms, but social connectedness seemed to protect against it. Now it seems sort of obvious when you think about it, doesn't it? But it's important to sort of quantify in the group that we're seeing because it gives us a few ideas about where to go to next. Now it's slightly underpowered, we're collecting more data, but it's interesting anyway. If we put them together, again, the key marker here seems to be social connection, right? It seems to mediate in the larger model as well, still significantly. And so that one has got us thinking a lot. Now, the other tiny bit that we've been doing to try and inform where to next is go back to the young people and say, well, how do you perceive change to occur during the treatment that you've had? So again, caveat, this is young people who reached a healthy weight, whatever that means for that person. These were not underweight young people at the end of treatment, but not everyone had reached a cognitive recovery of their symptoms, okay? And what people were saying is the key ingredients that impacted change for them was they talked about relationships as the vehicle or the mixing bowl in which the actual elements were created and mixed together. So if they had or could describe trusting, open and understanding relationships, or if the treatment could help them get there, that was the foundation upon which the other three really enacted, which were one, a sense of an awakening, a moment or a process, often internal, often not said out loud, of realizing something wasn't quite right. And if they kept going in this way, it wasn't going to work out so well for them, that they might want something different. Again, usually a very private experience. Then there was this idea that there had to be this realization, or I guess an environment generated within the family and with the multidisciplinary team that there was no avoiding anorexia, right? The only way out was through. You couldn't avoid it anyway, in any way that you went. And that there was always this importance of making sure we talked about life beyond the illness at all stages, right? Early on in treatment, it was very easy to get focused on food and eating and the next meal. And actually that could end up being counterproductive, right? So with those three elements combined in the kind of mixing bowl of relationships, people began to make small recovery-oriented steps with distress, right? And if that could sort of be tolerated and repeated and supported, you might get this tiny sliver of hope that the distress might be worth it. And if you can then start emphasizing life outside and making that bigger, you tended to be able to sort of decouple a bit from the illness, leave it behind and move to discharge. And I think what was most striking is that discharge was not considered recovery by almost everyone that we saw. Most people said that they were on the way, but actually they needed to be discharged to realize that they were okay. And it almost like took them to the next level of recovery, which I thought was also an important thing to mark. Now, when things got stuck in our treatments, when we looked at similar types of questions in our multifamily therapy programs, which are like intensive group-based interventions, or in our day program, the things that tended to get people back on track or engaged were intensity and immediacy, flexibility, peer connection, there's that thing again, right? And not just talking about things, doing, seeing, being, right? And it was through that that the containment could come and we could begin to get change again. Now I've had my 1 minute mark about 2 minutes ago, so I'm gonna be a bit quick. Where does that leave us? I think what it's left us thinking is we sort of can say it works for some or most people, but which bits actually work? What's the how and the why? And can we pull some of that qualitative data and from some of that quantitative data to bring together and maybe design specific components or evaluate quantitatively specific components or mechanisms that actually are effective and then match them to people, right? To profiles, to some of that like biotemperamental stuff that we were talking about, to more diverse groups, and then try and evaluate that quantitatively, because I think we're in a world now where we are increasingly online. We've got to disseminate more broadly. And what's interesting is this social connection theme that keeps coming up. What are we going to do with that in a world of online dissemination? And I'm going to leave it there. Thanks.
For one question. Yeah, here we have one question.
Hi, I was wondering, are there any situations in which, like when someone's seeing an eating disorder team, you would choose to bypass family therapy completely and go to something different as that person's first line?
Yeah, we do have individual approaches that are first line, even in our clinic as well. So I think the caveat to that is we would never just ignore the family. Like I think so saying someone's going to have an individual treatment, I think also just considers that person in context and would be about, well, if there are people around, why would we exclude them? But let's think together about how they can best be positioned to be supportive. So it's not an either or, it's kind of like a both and. Does that make sense?
Yeah.
Then thank you very much.
Thank you.